Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. My topic tonight is infertility, and my guest is Dr. Robert Stillman, Director Emeritus of the Shady Grove Fertility Center. Dr. Stillman, welcome to Housecall.
Thank you very much. Thanks for having me.
My pleasure. So briefly tell our viewers about your professional background.
I went to medical school at Georgetown and then Duke for my residency in obstetrics and gynecology and a fellowship in reproductive endocrinology at Harvard. And then I came here to GW to be the division director for 18 years before joining partners of mine as a threesome in Shady Grove Fertility. It was 1997 and was medical director there for 20 years and now medical director emeritus.
Very nice. And the Shady Grove Fertility Center, how does that compare to other centers around the country?
From a size perspective, is the largest fertility center in the country.
Really?
And the mothership is housed right here in Montgomery County. We are in Philadelphia and Baltimore and Atlanta and Tampa and a variety of other centers around mainly the Northeast. But it's the largest center. Size isn't the goal, but hopefully that's a reflection of success and patients referring family and friends to us.
Very nice. So most important, define for our viewers, what exactly is infertility?
Infertility is the inability to conceive a pregnancy after 12 months. It's a disease of the reproductive tract, and the definition implies regular cycles and regular intercourse. For a woman who doesn't have regular cycles, the 12 months becomes fungible, but that's the definition.
Okay. And how often do you find that the difficulty to conceive is not necessarily a woman's infertility, but rather the male partner?
Well, about 15% of couples are infertile, and about 40% of the time diagnoses can lead to disorders that affect the female. About 30 or 40% male, and there's some overlap where there's couples where may have both male and female fertility, and some remain unexplained infertility. They may be successful in treatment, but the exact diagnosis is unknown.
Looking at potential etiologies in women, what are some of the causes of infertility?
I think the most important one, a single one, would be age. The ovaries age over time. There's a finite number of eggs even from before birth, and that supply is limited. And if I had to have one question, one factor, or even one test, I think the age of the female would be the most likely to bring about the appropriate prognosis. So yes, there are older reproductive age women who conceive readily and younger women who don't, but age is a very important factor in the female, far less so and later in the male.
All right. So why does age adversely affect fertility?
Well, the eggs not only become fewer in number, but also they're in the ovary, back to high school biology, they're in the middle of a division, a meiotic division. Right. And it's a very delicate time for them to be for 20, 30, 40, 50 years. Keep in mind from a biologic perspective, hundreds and hundreds of years ago, the best time to conceive, or the only time to conceive, was women in their teens. And there are very wonderful social implications of later conception, but the ovary hasn't kept up with that. So the ovary is still thinking, I'm going to get pregnant when I'm 14, 15, 16. Now women in the 20s, 30s, 40s, and late 40s are still trying to conceive, and that has an adverse effect. Not only is it harder to conceive, but once a woman is pregnant, then the likelihood of miscarriages and or genetic problems, the classic is Down syndrome, are more prevalent. So it's kind of a double whammy.
And it's all because the eggs, so to speak, are older.
Yes.
Okay.
Yes, it's a delicate melding, shuffling of cards, so that each card in human reproduction needs to be separated by another. And anybody who wants to shuffle a deck can see that that's a hard thing to do. And anything that throws that alignment off can lead to lack of implantation of an embryo and or miscarriage. And those the eggs are in a very delicate spot for many, many years.
Besides age as the key variable, as you've mentioned, how often do you uncover that infertility is because of a structural problem, something with the fallopian tubes of the uterus?
Right. We do diagnostic tests that involve the uterus and the tubes. Hysterosalpingogram is an X-ray. Sonogram is used for saline, where we can pick up structural abnormalities. About 15–20% of infertility is related to tubal structure, blockage, obstruction, or uterine factors, fibroids, polyps, things of that sort.
And if you do find structural abnormalities, what do you do then?
Depends on the abnormality. Uterine ones, like polyps, we do generally remove surgically. Fallopian tube abnormalities are much less frequently treated surgically. The reason is the likelihood of success for what can be a major operative procedure, even with today's robotic surgeries and laparoscopic surgeries, the success rates are lower. So often we utilize in vitro fertilization as a bypass around the fallopian tubes, using our tube in a sense as opposed to the patient's own tube to try to get pregnant, with much higher success than with surgeries.
Now, besides looking for structural abnormalities, are there any sort of disease states you look for that can also reduce fertility?
Well, endometriosis is a common one, the uterine lining found outside in the body cavity. Polycystic ovaries, where the ovaries have multiple little tiny cysts in them, more than the usual, as a reflection of irregular and absent ovulation. Certainly male factor, of course, obstruction, vasectomy, or infection causing a blockage. And fibroids is another, at least of the uterus of the female, where there's multiple muscle tumors that grow and alter the anatomy.
What about general diseases like diabetes, thyroid disease? Can any of these affect one's fertility?
Yes, they can. They need to be fairly severe, and many of them affect the ongoing pregnancy once the patient is pregnant. So many diabetics can conceive if they have ovulation, but diabetes can complicate the pregnancy. Same thing with thyroid diseases. They can be treated directly. So endocrinologist, although we are reproductive endocrinologists, but endocrinologists will often have been treating that patient, thyroid disease and or diabetes. We often see them already having been treated and stable. Our goal is to have their obstetrician follow them during that pregnant state with their endocrinologist for treatment.
As you know, I'm a gastroenterologist, so of course I have to bring up a GI question.
Sure.
One of my own interests is celiac disease, wheat allergy, which can cause infertility.
Right.
Does your center routinely screen patients at the first encounter for celiac disease?
No, we don't. It's not a frequent cause, fortunately, and the patients often have excellent diagnostic care from centers such as yours.
Yeah.
So we often know about it, and the patient, again, is treated by their primary physician, primary in the sense being the subspecialist. So we don't screen for it directly.
Okay. All right. So once you've determined that somebody fulfills the criteria for infertility, and let's say you don't find any specific cause, I know our viewers are wondering, well, what about stress? Do you think there's anything to that claim that stress can cause infertility?
Right. I think stress makes the entire life crisis that is infertility much worse. It makes the journey much, much harder. Yes, there are certainly circumstances where stress can play a role in the actual infertility itself, whether it be through lack of frequency of intercourse or severe enough eating disorders and things that can interfere with ovulation. But in general, and I think it's ubiquitous, that individuals have stress and struggle while infertile. So I think it's important to provide not only the medical care to try to help patients overcome their infertility, but to support that journey along the way. And there are lots of services that we have at Shady Grove, for instance, that do that. There's a wellness center, which does acupuncture, massage therapy, nutrition counseling. There's all sorts of psychological support counseling for individual women, for men, for couples, for miscarriage groups, for patients going through donor egg, for single women, whole variety of support therapies. A huge online presence as well, social media, in addition to seminars and webinars. So there's a whole cadre of things that are used to support couples and individuals going through their difficult struggle.
So if somebody has now been defined as fulfilling the criteria for infertility, and you've put them through a workup and you don't find any obvious structural abnormality, what then is the next step?
Well, one of the things to consider is the use of inseminations, intrauterine inseminations, IUI, placing a single sperm sample centrifuged into the uterus. Mm-hmm. So what happens is there'll be an ejaculate, has a lot of material in it besides the sperm. You can centrifuge that out, concentrate it, and then, in a sense, a fancy pap smear, fancy in the sense of it's not much more elaborate than a pap smear, place that specimen into the uterine cavity to allow the sperm, highly motile fraction of the sperm, to try to find the egg, or eggs if you use medication, to improve fertility. And that's worth a non-intrusive, non-invasive trial for couples without diagnoses.
And what's your success rate with that? For among all, you take 100 infertile couples, what's the success rate with that?
Again, a spectrum based on reproductive age, but if you take overall, it's going to be only about 20%, which is really one of the disappointing things about intrauterine inseminations, which has led us to much more readily move or recommend consideration of in vitro fertilization, more complex, but much more likely to be successful.
And what is the next step then if that first trial has failed?
Well, in discussion with the couple, there are a number of factors. Some are reluctant to move to more aggressive therapies. Others have insurance issues that are important to take into account that may cover one type of therapy and not another. And often you'll utilize 2 or a third IUI treatment before feeling that the best thing to do is to move on.
You mentioned insurance coverage. For in vitro fertilization, is it generally covered, or are there exceptions?
It's quite variable. Maryland, fortunately, of course, which includes Montgomery County, is a partially mandated state. So, for instance, Massachusetts, fully mandated, all insurance covers in vitro fertilization. Maryland has a partial mandate, so that if a business has over 50 employees, and the employer, on behalf of the employees, asks an insurance company for coverage for IVF, then an insurance company cannot, by statute, say no. Okay. If it's less than 50, they can say yes, or they can say no. So there are many people in Maryland who are covered, not enough, but many people who are. Many state employees, police, teachers, fire, a variety of different individuals within Maryland are covered, but still not enough until everybody's covered.
Did the Affordable Care Act expand coverage?
No, it allowed a number of companies to request in vitro fertilization coverage, but it didn't particularly directly address the Affordable Care Act. One of the things we were able to get through was the military mandate, where individuals in the military who are infertile as a result of their service, accident or combat, have full in vitro fertilization coverage to try to conceive. And our office in Annapolis, Gil Motla, one of our partners, was instrumental nationally in getting that through. We're very proud of that for our military.
That's a wonderful accomplishment.
Yeah, we hope no one will ever use it, but unfortunately some have.
Right. So we're going to pause briefly for a public service announcement. When we return, more with Dr. Robert Stillman, and we'll be discussing infertility. We'll be right back.
Once there was a boy who did the same thing again and again. One day, he was told he had autism. He got help and slowly learned how to live with it better.
Early intervention can make a lifetime of difference. Learn the signs at autismspeaks.org.
We're back. My guest this evening is Dr. Robert Stillman, and we are discussing infertility. Dr. Stillman, when we paused for the break, we were discussing insurance coverage for IVF. If somebody is not covered, what is the projected cost of this important therapy?
There are a variety of options that Shady Grove in particular has for patients in this unfortunate situation. There's a single cycle cost, which can be just around $10,000 as kind of a global fee. There's a shared help, we call it, which based on a couple's financial status can get increasing reductions in the cost based on lower status. We have a military discount for all military personnel of 25% if they're active duty. We have multi-cycle discount plans where you have a couple of cycles and multiple transfers for a reduced fee compared to one then another.
Right.
And I think the most powerful one that many patients have found beneficial to them is what we call a shared risk 100% refund guarantee program. And it's basically if a patient doesn't have insurance, it's our own means of providing an insurance coverage. It's an insurance against being unsuccessful, in the sense that instead of doing one cycle and then another and then deciding the couple whether to pay one cycle at a time, they can get up to 6 cycles. Now, they rarely use 6, fortunately, but they can get up to 6 cycles for an increased fee compared to one cycle. And if at the end of the 6, or if they stop before the end of the 6, anytime, they get 100% refund if they have not had a baby.
Wow.
We only earn our fee if they have a baby, which is exactly aligning the goals of the couple and the center. Everybody wants them to have a baby. In fact, they want us to keep their money early, and it works out extremely well. So they don't want their money back in a sense. They want to have a baby. But if they are unsuccessful and stop at any time or finish the 6 cycles, then it mitigates our sense of loss in that we can at least give them their money back because we haven't done what we promised we could do.
So of 100 patients, couples that come to you
Right.
with infertility issues, with that sort of guarantee, warranty, whatever you want to
Right.
call it, what is your percentage success rate if they go up to like 5, 6 cycles?
Well, again, also very age dependent.
Yes.
So the younger patients may be 60% per cycle, maybe 85, 90% success rate in 3 cycles. Middle to later 30s, it goes down to 40 to 50%, and over 40, it drops precipitously from there. Our shared risk refund program actually stops after 40,
Right.
because the likelihood of success is lower, and there has to be at least a shared balance. So about 90-something% of our couples who are at Shady Grove are eligible for shared risk, but not at the extreme age ranges.
You mentioned age 40 and older. An interesting trend over the last few decades has been people, partly because they're involved with their careers, deferring marriage and ultimately parenthood until their 30s, 40s. Are you finding that with your centers as well?
Oh, yes, it's the most common cause of delayed conception,
Yeah.
is older reproductive age at which women seek to have their children. And many women and couples choose not to have children at all, as is their want. So the earlier one seeks care, or the earlier one tries to conceive, the greater the likelihood of a beneficial and successful outcome. Many women now have the option to freeze their eggs, to pause the fertility. So you can freeze your eggs at, say, 32 years of age, where fertility might be quite high, and then use them at 42. You have the genetic benefits of the eggs of a 32-year-old in the 42-year-old. It's an insurance against reproductive aging. Now, fortunately, many of the women may get pregnant on their own and not need to use the insurance, as much insurance is. Hopefully, you never use it.
Sure.
But if you do use it, then you're using the eggs from the 32-year-old. So that's become an important part of our practice, is providing that. It comes from the success of egg freezing. So years ago, egg freezing was only done for women about to undergo chemotherapy and radiation therapy at a young age for cancers.
Right.
And we called it fertile hope. and it provided a hope to be fertile if they survive the treatments, if they survive the disease after their treatment.
Sure.
And many, many women, more women were successful with therapies and are now using them. Problem was that 15, 20 years ago, the egg freezing process was not that successful. We did it anyway because what other hope was there? And some women succeeded and others didn't. Now the egg freezing is so successful that it's not only extremely successful for women having the cancer therapy, but now we can even offer it to women who are doing so electively.
Very nice.
Yeah.
Patient, couple comes to see you, and it's been agreed they're going to proceed with IVF, whether it's covered by insurance or not. So they leave at your conference room and conclude we're going to move forward. Tell us then what the follow-up steps are once that decision has been made.
Right. There's a whole series of steps to come up with a protocol, which is often used as a group of physicians. At Shady Grove, you have the benefit of hundreds of years of infertility and IVF experience. So a protocol is designed and transmitted through the team with the primary nurse for the patient. And the protocol involves medications based on the evaluation of the patient. Age, hormone levels, ultrasound evaluation of the ovaries. So the ovaries are stimulated with medications to develop more than one egg. IVF is quite successful in that it's a process of cheating. Mm-hmm. There are some people who do what's called natural cycle, single egg IVF, and that's very attractive thinking, but it's not very successful at all. So most of the success comes from a cheating process, more eggs. The eggs are monitored with ultrasound and blood work over a period of 10 to 12 days. Mm-hmm. An egg retrieval is done in our operating areas under sedation, intravenous sedation. The eggs are then fertilized in our embryology laboratory. The embryos grow over a period of 5 to 6 days and are either then frozen as embryos or transferred to the woman, mm-hmm. One at a time, generally. And then we see if she conceives. If she doesn't, then they often have the frozen remaining embryos for a further try, or often these days for a whole family from one cycle. You have 4 embryos, you transfer one, you may have 3 other children from the same cycle.
Interesting.
Yeah.
And when you do an IVF, as our viewers know, sometimes you get a blessing of riches. You have not one pregnancy, but multiple.
Correct.
Explain to our viewers what's happening there.
Well, the multiple pregnancies, an embryo can split as identical twins, but that's only very little increase compared to the natural occurrence. The multiple pregnancies that IVF is infamous for comes from transferring more than one embryo. Mm-hmm. So many years ago, the success rate from any one embryo was quite low. So to hedge the bet, you would put back 2 or 3 or 4, depending on the age of the woman. The problem was that often none implanted, or maybe 1, and that would be great, but sometimes 3 or 4 did. And we still needed to push that envelope in order to maintain success for the couple when conceiving one. As IVF has improved dramatically, the likelihood of any one of those 4 embryos implanting is much greater. So you can transfer 1 with the same success you could transfer 4 before, and not only freeze and save the others for another try or another baby, but also minimize the significant risks of multiple pregnancy from that one transfer. So Shady Grove has been at the forefront and has been part of my academic career to support widely the use of single embryo transfer, but it requires a good laboratory and good instructions to the patients that their success rates are still very, very high with a single embryo, avoiding the risks of prematurity and maternal complications for multiple pregnancy.
There is talk now that the science has become so elegant that you can even somewhat manipulate the gender of the baby. Tell us about that.
Well, we can't manipulate the gender as yet, and I hope that we won't reach that point. You can determine the gender of the embryo. Part of our increase in number of patients that we see comes from our genetic evaluations. So sometimes couples will come to us with a child they had a child with cystic fibrosis. And they're trying to avoid having another child with that same disease. So we can test the embryo prior to transfer in this non-infertile couple and transfer only embryos that wouldn't have cystic fibrosis. So that's one group of patients. Another group of patients is our own patients with difficulty getting pregnant, where prior to a transfer, you can actually biopsy the embryo, remove some of the cells, amazingly so with almost no harm over thousands and thousands of embryos, analyze the cells and determine the genetic normality of the embryo or abnormality, again, like Down syndrome is the classic example. But with that information also comes sex.
The gender, yeah.
And couples can, it's their information, it's their embryos, they can choose if they wish, if they have two excellent embryos, normal embryos, if they want to transfer a male or a female, they can make that determination.
Do you have couples that approach you not with any cystic fibrosis issues or Down's issue, but they just say to you, we want to have a specific gender child?
Right. We only treat couples with infertility. We don't do gender selection or in vitro fertilization as a social goal. If it's part of their treatment evaluation, then and the gender, the sex of the embryo can be known, then we allow the couples to have that.
And do you find that the accuracy of the checking the embryo pre-implantation is quite precise, so
Yes.
you could avoid implanting somebody with cystic fibrosis, Down syndrome, et cetera?
Yes, very precise. There are some embryos that are what's called mosaic, like a mosaic tile, that have some cells that may be normal and some not. And that's a much trickier balance as to, say, if that's the only embryo the couple has, whether to transfer that or not. But in general, that diagnostic capabilities, including finding a mosaic embryo, is extremely high. It's not perfect, but it's extremely high.
So we have 1 minute left, and our viewers will wonder, what about the safety of IVF? What are some of the potential side effects or risk?
Well, one of the common ones that's discussed is what's called ovarian hyperstimulation syndrome. And I like to say that all individuals going through IVF and stimulating the ovaries are being hyperstimulated. And in fact, that's one of the goals in order to get a number of eggs. Some women do have symptoms after that, fluid accumulation and difficulty with breathing for a period of time. That's fortunately with newer techniques, much less frequent. And the women do extremely well. It's a consequence of how well they've stimulated, but must be balanced with their good health.
Dr. Stillman, thank you for joining us on Housecall.
You're welcome. Thank you for having us.
My thanks to Dr. Robert Stillman for an excellent interview. My thanks to my team here at the station. And most important, my thanks to you, the viewer, for welcoming us into your home. Tell us how we're doing. You can reach me at my practice website, montgomerygastro.com. As for our next topic, it's going to be Dr. Joyce Coe, a community gastroenterologist, and she'll be discussing colon cancer screening and the latest therapies for hepatitis B and hepatitis C. It's going to be a fascinating show. See you then next time for another edition of Housecall. Good evening.